So now I'm going to discuss about the fibula. Very complicated bone, very thin bone. This is the post-axial bone. You can see here already I have discussed. So we should study together. Let's know something about fibula separately. Same like long bone, shaft, upper end, lower end. We should say head of the fibula. The upper part you can get, this is a facet. Just now I was telling the facet for the upper or superior tibiofibular joint. This is not coming into the knee joint, whereas lower part, lower tibiofibular joint, that is forming the tibiofibular mortis and attached with the talus, that is forming the ankle joint. So this upper part, this is the facet for this superior tibiofibular joint, and just behind this or posterior to this facet we are getting the styloid process. So we are getting the styloid process here. This is, we can see where the facet for the superior tibiofibular joint. So posterior to this facet, that is the styloid process, where the fibular collateral ligament, arcuate ligaments, they are attached, and just anterior to this styloid process, this is a space where the biceps tendon is getting attached. So you can see there, just now I was showing the semitendinosus, the lower medial part, where the semitendinosus and the biceps both are originating. The biceps is coming like this way, longer biceps, and this is the lateral supracondylar line. The upper part we are getting the shorter biceps, both they coming and together joining and attached to this just anterior part of the styloid process of the fibula. Okay. So this is all about the head. Then this constricted part is called the neck. Very, very important. Neck, clinically fracture neck of the fibula, because one important nerve, once we study the popliteal fossa, we will see here we know that sciatic nerve is coming and dividing, is the lateral part, is the common peroneal part, is the tibial part, common peroneal part is coming here, and the neck of the fibula, lateral to the neck of the fibula, is divided into superficial and deep part. So that's why if there is any injury at this, the neck of the fibula, this nerve gets injured. And we'll get the interossei membrane once we study the borders. Then we'll say the anterior border, the shaft is an interossei border, and one is the posterior border. You can say the medial border or interossei border. So here you will get the interossei membrane in between the tibia and fibula, but in the upper part there is a gap through which the anterior tibial vessels, from here anterior tibial vessels are coming and coming out like this way. So this neck of the fibula is so important. It is laterally we are getting the common peroneal nerve, and medially we are getting the anterior tibial vessels. Okay. So in the shaft, if we see anterior shaft border, we can get it. So where the anterior intermuscular septum is getting attached. So in between this anterior border of this fibula and anterior border of this tibia, this is the anterior compartment where our extensor compartment, where the extensor muscles are coming to the dorsal part of the foot. So this is the anterior border. Then we can see this is the interossei border. So this interossei border and the lateral border of the tibia, there the interossei membrane is attached, which is deposited here in the upper part, through which the anterior vessels are coming out. So this is the medial surface, we can say, in between the anterior border and the interossei border, where three muscles, though this very small area, but three muscles are there. I will discuss now. And this is the anterior border and the posterior border. So that is the lateral surface, where upper part the peroneus longus, lower part peroneus brevis. So here in between this here in this medial surface, in between the anterior border and the medial border or interosseous border, the upper almost maximum area, 3/4 area will get attachment of extensor digitorum longus. Okay, then this whole attachment of the extensor digitorum longus, the middle part of this extensor digitorum longus, medial to this extensor digitorum longus, here we'll get the extensor hallucis longus, and the lower part, lower 1/3, we are getting the peroneus tarsius. So these three muscles, they are coming. So that's what I was telling here. The four muscles are coming. Here is the tibialis anterior. In the upper part, we are getting almost 3/4 part, we are getting the tibial extensor digitorum longus. Then medial to the extensor digitorum longus, the middle part, we are getting the extensor hallucis longus, and the lower part of this fibula in the anterior compartment, we are getting the peroneus tarsius. So these are the muscles are there for the extensor compartment. They are coming here below the extensor retinaculum. We will study afterwards the seriality from medial to lateral, tibialis anterior, extensor hallucis, then neurovascular structures, then extensor digitorum and peroneus tarsius. This is the seriality on the below the extensor retinaculum. So now coming to the, already I have described the lateral part, peroneus longus, peroneus brevis. Now coming to the posterior side, posterior surface in between the lateral border and the medial border, or the interosseous border. The same like here we have seen. So we have seen the tibia. This was the anterior border. This was the lateral border or interosseous border, and this is the medial border. So this is the medial surface, lateral surface, and posterior surface. In posterior surface, we are getting a vertical crease, vertical line. So this is the right sided. So now you can see this part is the lateral, this is the medial. So here the fibula is there. You have to imagine like this way. So what we have seen, this is the posterior surface. It is divided by this vertical line. So this part we are getting the flexor digitorum longus, whereas this part we are getting the tibialis posterior. In the same way, if we see the posterior surface of the fibula in between the posterior border and the interosseous border, here also we are getting one thin line, thin vertical crease, where this is the medial part because it is rotated like this. So this is the right sided, this is the medial part. Here we get the tibialis posterior again, because tibialis posterior is having a huge origin, which is from the lateral surface of this posterior surface and this the medial surface on top of the interosseous membrane. So this part, the tibialis posterior, here we are getting the flexor digitorum longus, and this lateral part we are getting the flexor hallucis longus. And we have seen this is the soleal line. So this upper part of this posterior surface we are getting the origin of soleus. So soleus muscle is getting originated like this way. We know the calf muscles because two gastrocnemius, they are originating from the condyles of the femur. They are not originating from here, and this is coming like this way. And gastrocnemius and the soleus, they are together coming and forming the Achilles tendon in the calcaneum. Okay, so that we will discuss afterwards. We can show you in the dissection. So once we cut this gastrocnemius, then we will see the soleus. Here one muscle we will see, fine slender muscle is a plantaris, because we have seen that is the posterior part, the lateral condylar line. Here is the shoulder of the biceps. Here is the plantaris. So that muscle will come below this gastrocnemius. Gastrocnemius are coming like this way. So below, in between the gastrocnemius and soleus, you will get this plantaris muscle. I will show you in the dissection. So this is the posterior surface. We got these muscles. So this is the tibialis posterior. That's why this is the groove for the tibialis posterior. This huge muscle tibialis posterior is coming. Here is the flexor digitorum longus, flexor hallucis longus. Here is the soleus. So now coming to the lower part of the, because still now I have not described about the side determination, very important, and the ossification, where many times it is asked in the exam. There is some disparity in the ossification of the fibula. I will discuss it. Before that, you should know about the lower end. So now I am going to describe the lower end of the fibula, where you can see this is the extended portion. So that is the lateral malleolus, the same thing what we have seen in the medial malleolus in the tibia. Tip of the lateral malleolus, it is almost 1 centimeter below the medial malleolus. And it is having anterior border, lateral surface, medial surface, posterior surface. Okay. And the anterior border, we are getting the attachment because here is the anterior joint is forming. So here we will get the talus. So anterior talofibular ligament. Name itself is telling talofibular. Laterally we will see the calcaneum. So we are getting the calcaneofibular ligament. Okay. Now coming to the medial surface, you can see here on facet. This facet is for, because here tibia and fibula, they are forming the tibiofibular mortise. Okay. Once it is forming tibiofibular, this is the mortise, where the head of the talus is getting, and that is the stability of this ankle joint. So this part is the facet, the medial surface. You can see this is a facet that is for the lateral surface of this upper end of the talus. Very important thing. Now just behind and below, you're getting a depression. So that is the most important thing. There is the malleolar fossa. That is the malleolar fossa which will guide you for the side determination. I will tell you just now. So this malleolar fossa, where you will get, if you see, so here you can see this is the malleolar fossa. So where, because here the talus is coming, so here we will get the posterior talofibular ligament, and the most important, inferior transverse, this transverse, inferior transverse tibiofibular ligament, very important ligament. So these ligaments are helping the stability of this tibiofibular mortise. So this is the malleolar fossa, where we are getting the inferior transverse tibiofibular ligament, and here posteriorly we will get the posterior talofibular ligament. So now I will explain how to tell about the side determination. So once you hold the fibula, the head, lower end, malleolus should be laterally. It can be like this also. It can be this also. See this malleolar fossa. You hold this malleolar fossa with your thumb, because malleolar fossa should be posterior to this facet for the talus. If it is right-sided, so I am holding like this. It will be possible to hold like the right-sided fibula, putting your thumb on this malleolar fossa, or if you are clever enough, so you see, first you see this facet for this talus, and malleolar fossa should be posteriorly. If I am holding like this way, so we can see, if I am telling this is left-sided fibula, But why not? Because you can see this malleolar fossa is anterior to this facet. Malleolar fossa should be posterior to this facet. So if you see like this way, the malleolar fossa is coming posterior to the, so this has to be the right-sided fibula. This is not left-sided fibula. Okay? Because these borders, if you try to find out with the borders, they are so tricky, you may not appreciate properly. So that's why the best thing for the side determination to see the malleolar fossa should be posterior to the facet. So it has to be the right-sided, and I am holding it. If it is a left-sided, I cannot hold it with my thumb because the malleolar fossa gone anterior. So that's why I cannot hold it with the thumb. But if I am trying, it is hold it because I am putting my tip of the thumb on the malleolar fossa. This is one way, or you can see the facet and the malleolar fossa should be posterior. In that way you can find out which side of the fibula. I think, and the lower part, you will get a depression here because I have told you the lateral surface where you get two peroneus longus, peroneus brevis, this two muscle will come and giving a depression because they are coming to the foot. So there is a depression for the peroneus longus, peroneus brevis. The same way you got a depression in the posterior part of the tibia. There is a tibia is posterior. So now coming to the ossification. Primary centers appears at about 8 peak of intravenous life. So before knowing this appearance of the secondary center, we should know this is such a bone. Upper part is having the traction epiphysis because here the biceps tendon is attached, so it is giving traction. So this epiphysis is example of traction epiphysis, whereas the lower end is forming the ankle joint, which is the example of pressure epiphysis. But if you compare with the tibia, both the side is actually pressure epiphysis. So the laws of the epiphysis with the ossification, appearance of the secondary center, if both the sides are having same type of epiphysis, if this is pressure epiphysis, this is also pressure epiphysis. If this is traction epiphysis, this is also traction epiphysis. If both the side, both the epiphyses are of same kind of epiphysis, then the secondary ossification center will appear as a proximo-distal way. So first this will appear, then this will appear. You can see here in the tibia. So this is also pressure epiphysis. This is also pressure epiphysis. This is also pressure epiphysis. This ossification center appeared first, just after birth. This is late. So they have followed the proper rule of the ossification. Here, this part is pressure epiphysis, this part is traction epiphysis. As per law, if there is the different epiphyses are there, the both ends of this long bone, the pressure epiphysis, the epiphysis, secondary center for the epiphysis for the pressure epiphysis, secondary center for the pressure epiphysis will appear first. Then the secondary center for the traction epiphysis will appear. So that's why here the secondary center is appearing for this pressure epiphysis by the age of 1 to 2 years, whereas this traction epiphysis by the age of 3 to 4 years. So as the secondary center appears by the age of 1 to 2 years, so it appears first, then this, so automatically this should unite last as per laws of ossification. But if we see the nutrient foramen, we know nutrient foramen, you can see here it is directed downwards. So that means this is the growing end. As the nutrient foramen is directed downward, this end, lower end will ossify fast. So that means the appearance of this secondary center of this lower end is coming fast, it is uniting also fast. So that is not following the rule of the ossification, that is violating the rule of ossification. The secondary center which is appearing fast will unite last. But here in the lower end of the fibula, because of this pressure epiphysis, it is appearing fast, and because of this nutrient foramen directed towards the lower end, growing end is upper part, so this is united first. So that is the most important thing in the fibula, why this is not following the rule of ossification. The side, we can see here the tibia, here the upper end, secondary center appearing first and this ossifying last, whereas the lower end, both the ends are pressure epiphys. That's why lower end is a proximo-distal manner, so this will appear last and here it will ossify fast. So that is following the proper rule of the ossification, whereas in the fibula it is not following, because the pressure epiphysis is appearing fast because of the nutrient artery downwards. This is the growing end, this is uniting fast. So this is the interesting part of the ossification of the fibula. So this is almost everything I have described of the fibula. We can study the rest of the things and we can revise afterwards to mention the other important points. Thank you.